Many thanks for asking me to speak. And the topic I'm going to cover is looking at non-infectious comorbidities in those who have been born with HIV, have lived their whole lives with HIV, and are now approaching the 5th decade of life. We're going to look a little bit about the epidemiology, about mortality in adult care, and the impact of factors in your childhood that influence the rest of your life. We're going to focus on cardiovascular, metabolic, renal and respiratory outcomes, but with the caveat that this is an emerging cohort who've lived with HIV for their whole lives, so for 30 or 40 years, but studies are often single centre or single country with small numbers, observational and very variable controls. We're then going to look at the data gaps and the way we might move forward. So over 11 million children have been born with HIV since the early 1990s. 2/3 of a million are now aged 20 to 24. Unfortunately, we have no idea the number globally who are aged 25 and over. But what we do know is due to failure of prevention of vertical transmission, 120,000 infants were diagnosed in 2023, and so the problem isn't going away. And this is what happens in the UK. We have free access to healthcare. Young people transition to adult services around the age of 18, and you can see now that more than 80% are well embedded in adult services, and some indeed are over 40. So when we think of those living with lifelong HIV, we can almost think of them in two cohorts. Those who were born in the pre-ART era, so prior to 1997, infants born with HIV in sub-Saharan Africa, where the majority have been born, 50% will die before their second birthday. So those are now over 25 years of age. There is a survivor bias. They had slower degrees disease progression. They had to survive without antiretroviral therapy. They very likely had favorable both host genetics and immune responses. But the caveat to that is, of course, they've lived with many more years of unsuppressed viremia when you compare them to those who are now under 25, who were treated earlier, have had less years of viremia, have had more modern, less toxic regimens. However, that group does include some of those infants who presented with HIV encephalopathy, PCP and CMV, who had very torrid stays on intensive care units, often for months, before surviving, and have the long-term sequelae of some of those issues. So when we look at what happens when you move to adult care, this is data from the UK, you can see there's a 10% risk within 5 years of transitioning to adult services of a new AIDS diagnosis or death. And actually it's very predictable as you leave paediatric care. If you have viremia as you exit paediatrics, the lower your CD4 count, the more likely you are to die. It's very difficult to turn things around moving to adult care. And we see actually a very similar picture in terms of hospital admissions and the burden that is on healthcare systems being 4 times higher, 20 to 35-year-olds, when compared to the older, what you would consider as the aging population, those in their 60s and 70s living with HIV. But I think we have to remember that adults in their 60s and 70s may have lived with HIV for 30 years. But this cohort have also lived with HIV for 30 years, and they have had the impact of HIV viremia and increasingly of antiretroviral therapy on the whole of postnatal childhood and adolescent growth and development. And that is slightly different to acquiring HIV on a mature system, including a mature immune system. And it's not just your HIV care. What else happens in childhood is incredibly important. So adverse childhood experiences, if you've experienced more than 6, you will die 20 years earlier than if you have had no adversities. And that includes things like parental violence, divorce, abuse, neglect. And for those who have been born with HIV, certainly in my setting, 50% are migrants to the UK, 50% are single or double orphans, and up to 25% live with some form of learning disability, ranging from a mild learning disability to non-verbal autism and HIV encephalopathy requiring wheelchair use with a hypertonic diplegia. So we can see that there are multiple factors, and these are very difficult to control for when we're looking at studies of what the outcomes are for adults born with lifelong HIV. I think there is a changing picture. We know that mortality, despite suppressive antiretroviral therapy in multiple high-income settings, is about 10 times their negative peers. Generally, it's been associated with opportunistic infections and HIV-associated malignancies and not comorbidities. But certainly in my clinic, what we have seen initially was AIDS-defining diagnoses with infection in the early 2000s causing deaths. And then we had a period where we saw malignancies. So this is a hepatocellular carcinoma and a cerebral B-cell lymphoma. But the last two deaths we've had have both been in adults on suppressive antiretroviral therapy, both found dead in their homes. The first at post-mortem had evidence of a DVT and PE, but no other risk factors for that. And the second was felt at post-mortem that it was a likely arrhythmia, no other cause of death found. So are we moving a changing clinical picture, looking more at the comorbidities? And when we look at the metabolic and cardiovascular outcomes, this is in US data in the NA Accord cohort, that the estimated cumulative incidence by the time you turn 30, so you've lived with HIV for 30 years, 1 in 5 will have type 2 diabetes, 50% will have abnormal lipid profile, and 22% hypertension. And the risk factors are the years of HIV exposure, chronic immune activation, some association with worse metabolic outcomes with protease inhibitors, and also the traditional risk factors. And what you can see is an increase over time, and matched with population data that does have some difficulties, but you can see that rates of type 2 diabetes are 3 to 6 times, of hypertension of 1.5 times, of dyslipidemia of 2 to 3 times, and of chronic kidney disease 4 times. So focusing on the metabolic outcomes, even when you control for BMI, and even in countries, say, not like the US that have lower rates of obesity, such as France and Thailand, we see increased rates of the metabolic syndrome in those living with HIV from birth. However, that's not universal, because in South Africa, those with perinatally acquired HIV had lower rates of the metabolic syndrome compared to those who had acquired HIV in later life. We do see a fairly uniform picture of reduced insulin sensitivity associated with increasing age, so as you move from adolescence to an adult life, and associated with immune activation and gut permeability. We also see increased rates of hepatic steatosis that aren't fully explained by metabolic factors. And there is this sort of image that is emerging of adults with perinatally acquired HIV who are thin but have a dyslipidemia phenotype, so not all driven by traditional risk factor of obesity. Looking at the cardiovascular outcome, this is difficult. Assessing cardiovascular risk in those under 30, there is very limited data. And also, we are aware in adults of the difficulties of using tools that aren't adjusted for HIV. What we do know in the perinatal cohort is that cardiovascular disease was very prevalent in the pre-ART era and hasn't completely been ameliorated by suppressive ART. We see subclinical abnormalities in structure and function, including myocardial fibrosis, and these are worse the later ART is started. We also see increased carotid intermediate thickness and impaired endothelial function. And when looking at scoring systems, so the pathological determinants of atherosclerosis in youth is validated in the under 40s, is based on post-mortem data in the general population as a predictor of atherosclerotic cardiovascular disease. And we see raised scores in up to 2/3 of those living with perinatally acquired HIV, in part driven by hypertension. But this scoring, again, is not adjusted for living with HIV. I think we have to be really careful in extrapolating data from high-income settings to sub-Saharan Africa, where the vast majority of adolescents and young adults with perinatally acquired HIV live. And this is data from this year's CROI that showed really quite marked differences by country, comparing Uganda and the states, looking at chemokine and inflammatory profiles. But also, when you broke down those living in Uganda, really very different signatures between those who lived urban lives and those who lived rurally. So it's just, it's very difficult to know whether can we extrapolate from those born in the pre-ART era to those who are coming up having many more years of suppressive therapy, but also even within countries, there are differences. When we look at renal outcomes, the HORE data prediction by the age of 30, 4% chronic kidney disease and EGFR less than 60, but 25% had abnormal renal function. In children living with HIV, we see higher rates of renal disease in sub-Saharan Africa and in those of Black ethnicity. And looking at adults with perinatally acquired HIV, so young adults, around 12% pooled chronic kidney disease. Associated with increasing age, increasing years of HIV, uncontrolled viremia, CD8 activation, and the traditional risk factors of hypertension, hyperglycemia, sickle cell disease, Black ethnicity. And this is just 2 young adults in our clinic. One had an HIV-associated lymphoma, had a bone marrow transplant, which he survived, but unfortunately has then gone into chronic renal failure and is awaiting transplant. And the second case is a young woman who presented in her early teens with HIV, nephropathy, and renal failure, and with suppressive antiretroviral therapy actually made some very good progress, but had some persistent proteinuria. And unfortunately, she did very well for about 15 years, but over the last 5 or 6 years is progressing into renal failure, despite suppressive antiretroviral therapy on dolutegravir, lamivudine, so still on first-line therapy. Moving to respiratory, this is Lucy. This is the first child I ever admitted to pediatric intensive care with HIV. She presented with respiratory failure due to VZV pneumonitis and actually did quite well, was extubated after 10 days, started antiretroviral therapy and generally had pretty good adherence, although the occasional intermittent time off therapy. But what we saw is increasing cough and breathlessness, and by the time she was 21, her FEV1 was only 33% of predicted, and you can see the changes in her chest x-ray. No other cause was found. At this time, she was pretty much sustained suppression. She had a very good CD4 count, a normal CD4-CD8 ratio. Screening for sarcoid was negative, but she was felt to have for progressive fibrotic lung disease, sort of sarcoid LIP-like. Now, there's very little published data actually on respiratory outcomes in adults living with lifelong HIV. Most of it stops at 18, but we know from adults who acquire HIV in later life that late diagnosis, more severe disease, ever having PCP, ever having LIP, TB and CMV, and plus all the traditional risk factors, which include for my cohort being born in Africa, poverty, stunting and malnutrition, impact on respiratory function. When we look at the data that is published in adolescents, and much of this comes from Rashida Farran's group in Zimbabwe, but up to 60% have chronic cough. Almost 1 in 5 is short of breath, and a third have abnormal spirometry. The main clinical picture is of bronchiectasis and obliterative bronchiolitis, and is validated well by CT scanning. Associated with chronic inflammation with T cell and platelet activation. is improved by early, and when early we mean infants less than 6 months, and you're talking about early sustained, i.e. potentially lifelong suppressive antiretroviral therapy from infancy, does improve total lung capacity, but probably less so small airways diseases. Rates of respiratory compromise are lower in high-income countries, but even in the UK, 8% have bronchiectasis, and almost 1 in 5 have abnormal chest X-ray findings. So continuing to Lucy, she's now working as a teen teacher, and actually she has recurrent admissions to hospital, but gets pregnant. Has a relatively complicated pregnancy course. We managed to get to 36 weeks with slight growth retarded baby. She's on aspirin and enoxaparin, and her daughter is born HIV negative, but does, as the years go by, emerge to have autistic spectrum disorder. And I think that's where adults with HIV who've lived with HIV for 30 years, acquired in adult life, they're in their 60s and 70s. They are not getting pregnant. So the comorbidities of hypertension, of chronic kidney disease, of dyslipidemia, of poor glucose control, you then put the stress of pregnancy. And this translates to increased risk for postpartum mortality. And this is data from the States, looking at postpartum mortality adjusted for both age and CD4 count. And you can see that it's over twice that of women who've acquired HIV in later life. And I think that is a real difference for young people living with lifelong HIV. So Lucy, we tried pulse methylprednisolone. She is assessed for transplant, but it's felt to be technically too difficult. She has her first admission to ITU, and for me, that was, I admitted her to ITU as a 3-year-old, and to see her readmitted and her mum back on an intensive care unit, but this time with her granddaughter, is pretty heartbreaking. We've tried MMF, further pulse suppressed, and she's now on home ventilation. So despite viral suppression, in those born with HIV who've lived for over 30 years with HIV and increasingly with prolonged antiretroviral therapy exposure, we do see signs of sort of early aging in cardiometabolic respiratory, but also we haven't touched really on sexual and reproductive and neurocognitive and mental health. Data gaps. So do the outcomes of our current 30-year-olds, will they reflect the next generation? Will the subclinical cardiovascular findings translate into early disease? Does early infant antiretroviral therapy prevent such comorbidities? And how do we achieve this? And how do we sustain viral suppression throughout childhood and adulthood? And should we be considering, we recommend statins for every adult from 40, but should we be considering earlier statins, antihypertensives, and immunomodulators, with the recognition that many young people struggle with adherence to antiretroviral therapy and viral suppression has to be the primary goal, and adding further pill burden may impact on that. So I think the starting point, there are multi-country discussions going on now as to how do we effectively link pediatric adult data sets with data sets such as oncological mortality data sets, so that we can work out a clearer picture, and with that much better data, look at interventional studies moving forward. So I'd like to thank the children, adolescents, young adults, and not so young adults of our service, and all the fantastic people I work with. I've worked with the same group of young people born with HIV for nearly 30 years, and it's been an utter privilege. Thank you.